Good afternoon again, everyone. Good to see you. Well, some of you. Hey, Danielle. So welcome again to our Telehealth Learning Collaborative. My name is David Johnson. I'm the Telemedicine Program Coordinator for the Fort Drum Regional Health Planning Organization. We have a pretty jam-packed schedule for today's meeting. I'm trying to see if Joan Sicard has joined. Joan, are you out there? Yep, not seeing her yet. So made a couple changes to the agenda. As soon as Joan Sicard can join us, we want to put her up front, right at the top. As soon as she's able to join, for an update on the Department of Health regulations. Rayanne, you're on the call now. Do you have any idea if she's going to join like soon or?
If she was able to join, she said it would be right at 2 p.m. So if you want to give her another couple of minutes, that's fine. Otherwise, I can provide an update on her behalf.
Okay. I'll tell you what. I think that we have Mary Beth McCall on the line. Mary Beth, are you there?
I am. Can you hear me?
That's great. So I'm going to just jump right in here, talk a little bit about what's happened with Excelis, and then give Mary Beth an opportunity to share it as well. So you remember from last month's discussion that we talked about Excelis' statement on reimbursement for telehealth visits. As a result of that, we had our executive director, Denise Young, traveled to Albany and met with some of our legislators. So she met with at least three, Senator Young, Senator Patty Ritchie, and Assemblywoman Russell. Kind of talked about what was happening around the parity law in New York State, and some of the things that we thought were important for those legislators to know. We produced a briefing, which I'll email to all of our participants today, so you can see that briefing that we prepared for them. And then, as a result of that, Senator Patty Ritchie, along with Wade Abbott, Wade's on the line as well, produced a letter to the Commissioner of Insurance. And many of you probably have seen in relatively short order, Senator Young and Senator Ritchie co-sponsored Senate Bill 7953, which is it's very similar to the language that Minnesota uses for their reimbursement policy. So it's no longer just coverage, but a true payment parity law. So we've also been talking and continuing to work with Excelis. And Mary Beth, do you want to just share, where you guys are at and the steps that you've taken so far? You can share your screen as well.
Unfortunately, I can't share my screen because I don't have a video cam with me.
Okay.
Can you hear me though?
Can hear you fine. Yeah.
Okay, terrific. As you know, we've been significant supporters of telemedicine, and we were really working on two paths at the same time. One was the telehealth mandate, and the other was choosing and developing a telemedicine program for urgent care and ED avoidance. And so those were in parallel paths. We did indeed choose a vendor for our ED and urgent care avoidance. And we were able to obtain a really good price for the per visit visits at a very good price. And so when we looked to discover on whether people would do their own urgent care avoidance by other methods, we wanted to make sure that we didn't pay one group at a higher rate, and that's really where we looked at using the modifier GT for reduction, specifically because of this really good price we got on our urgent care avoidance group, our vendor. When when the policy was discussed and felt to be the GT, the 50% reduction in an E&M for urgent care would really come out the same as the good price that we got for our urgent care avoidance. It was felt that that would be a reasonable way to implement, related to how many other plans had implemented a reduction related to the efficiency and reduced practice overhead of an urgent care avoidance visit by a physician. We did, however, recognize that we had some programs that were developed and set up not for urgent care avoidance, but for delivering subspecialty care or shortage care in our regions, and we did not want to adversely affect them. And so we're working on developing a process to identify the programs that have been developed for physician shortage with the organizations as yours with Fort Drum, specifically to be able to maintain those programs without the reduction. So I contacted Corey and David to get a list of the current projects in place. We will have to do some adjusting of our claims processing systems to not have the modifier hit on the on those programs, we'll be looking at what the benefit of each of the programs is. So does that make sense to you, David, and to the team?
It does. Let me kind of open it up and have people. I'm going to unmute everyone. We'll see how it goes.
David, before you unmute, could you say, was the payment parity bill passed in the legislature?
No, it was just presented.
Okay.
Latoya, maybe you can help us with this, or Wade, perhaps. I think it probably will need to be reintroduced if it doesn't go through this session. Is that? Do I have that?
That's correct.
Right? Okay.
Yeah, that's correct. Right now, looks like it was introduced end of May by Senator Young, co-sponsored by Senator Ritchie, and then the Assembly version, same as version, which is good that there's actually both houses have a version of the bill that is identical, and that's Assemblywoman Russell. So those were introduced, but unfortunately, end of session, it's kind of a busy time, so they didn't move out of their respective committees. So we will be at the start of a new session in January, and it would need to be reintroduced at that point in time.
Yeah, thanks for that.
I know it was pretty confusing for us when we were first looking at, when it came out saying it was a parity law, and yet it was really based on the members' parity, that it was just not to be disadvantageous to a member or a patient, and it really didn't have the, some of the details about payment parity. And we do know that we're always looking at ways of reducing cost of care because, other technology is increasing, so we have to work on seeing how we can be efficient, and the efficiency of not having a waiting room and a roomer, for urgent care avoidance really does speak to reducing fees.
Yep, it does. So we certainly appreciate the work that Excellus has been doing, and especially in developing some ways that we can, for our specialty care, not see that reduction in reimbursement. Love what Mary Beth and her team are working on there. We'll still have to determine the process for that. And another thing that we offered to Mary Beth was to kind of be a central kind of consolidator of projects. That's a possibility for others who might apply for this, what we call grandfathering. But I'm going to unmute the lines now, and if you could actually, underneath your attender section, there's a place where you can like raise your hand. Do you see that raise your hand button? So you could click that raised hand, and I could open up the line. Hey, there's a question. It looks like Averill George. Averill, I think you're unmuted now. Maybe not. Let's see. No? Try that again. How about Julie Marie? Are you?
Can you hear me?
I can. There's Julie Marie.
Just a quick question on the sites that are currently doing telemedicine in those provider areas where we are a site that has been doing it previously. Is there going to be communication with our site specifically that we're sort of in the system to allow future payments to be paid at the previous rate, or a database that we should be checking to make sure we're in there? What is the process for that?
I think that's directed toward you, Mary Beth.
Yeah, sorry, it's for Mary Beth.
Yep. Oh, I think I muted everybody there. Sorry.
Thank you very much, David.
Sorry about that. Go ahead.
I can see you unmuted me, so I'm good.
Okay.
We started with gathering up a list of providers and programs that were that David was aware of, and we're bringing those through our provider relations group to identify NPIs and tax ID numbers, so that we can work on developing a mechanism to have that modifier not fire. I'm not sure exactly how that's going to be done right now. We have a team working on it within the claim system, trying to figure out how we can do the most efficacious. But in the interim, you can, David, is that group on the list?
It is on the list. Yep. So North Country Family is on that list.
Okay, terrific.
Here's a question from Averill George. He typed it in because I apparently couldn't unmute him or something. But Averill is a ID doc and starting a telemedicine ID practice this fall. And so his question is Excelis going to recognize internal medicine subspecialties? I think what he's asking is there a way to have that not drop down to the 50% reimbursement?
What I have right now as my response from my senior management is programs that have been developed for shortage specialties in the North Country related to Fort Drum. We will try and fix that. Now, we would have to have it as a designated shortage, which I believe internal med might be, but again, I don't know what region you're going to be working out of or to. So I think that's the devil in the details thing.
Mm-hmm. Okay.
Doctor, but I know that infectious disease is one of those specialties that really does very well with telemedicine. With the ability to review lab work, see the patient, and then deal with the specialist, the internist on site.
Okay. Other questions? Let's see. Looking for a raised hand. I'm not seeing any. Any other follow-up for Mary Beth? All right. It's very exciting news. So we're appreciative of what Excelis is doing and appreciative of the progress that we're making legislatively as well. Any questions on the?
It's always better when it's a level playing field. So I appreciate your political efforts.
Thanks so much, Mary Beth.
Thank you. Thank you.
Any other questions on the legislative piece or comments? Let's say. Latoya, do you have any thoughts?
My only thoughts are kudos to you all for doing what I consider to be such an impressive job in such a short amount of time. Even though legislatively the bills aren't going to go anywhere this year, you've got some amazing state legislative champions, and I know I certainly will put an asterisk by this and share this information with the rest of our membership. And I think it's awesome that you also have a representative from Excellus in the call. You've got a great working relationship with them. So thanks at least just for including ATA on this, but awesome job.
I appreciate that so much, Latoya. Thank you. And yeah, we have a really good team. All right. Rayanne, I think that Joan might have been on quickly and then dropped off. So I'll let you give the update on the regulations if people haven't seen that already.
Okay. The telehealth reimbursement regulations that the department has been drafting, that effort has been spearheaded by the Office of Health Insurance Programs, and the primary contact on that is Joan Seacard, who we had hoped would be able to join for a few minutes today, but I have a little update on her behalf. The latest draft probably should have been received. David said he had received them just today, I believe. The draft regs are being circulated through the PPSs, through their leadership, and they have a fairly quick turnaround time of close of business June 29th. So hopefully everyone has received those. If not, David, I'm sure, could probably forward them on. I think you guys said the last version you had seen was version 12, and this version that's been sent out is version 16. So just a couple of highlights of how that differs from previous versions. I believe they removed a section that was related to specific Medicaid fee-for-service reimbursement and some billing guidance, and have decided that that information will instead be published in a future Medicaid update rather than being included in the regs, which would make sense. And the latest version also adds some reference to the O agencies, OMH, OASAS, OPWDD, to try to add some greater clarity with regard to delivering telehealth, delivering services via telehealth in and across those settings. So those are a couple of the changes that you'll see. We're glad that these are out for comment. Once that feedback is given, and further, we're expecting further edits might be made after that feedback is gathered, that version would then go to the department's Division of Legal Affairs for review and approval and published in the state register. So as many of you are aware, once it's in the state register, there's another 45-day comment period where written comments can be submitted to the department. But in the interim, you're able to go ahead and look at them now, provide any feedback and comments now through the mechanisms spelled out by your PPS leadership. And hopefully by the time they come out officially, they'll be in very good shape and ready to go. Do folks have any questions about the telehealth regs?
If you have a question for Ann on that, just raise your hand for me again. Hal Smith, let me see if I can unmute you for a second here. How's that work, Hal?
You got me?
I think we can hear you, yep.
Okay. I saw the draft this morning, as probably everyone else, and for OMH, it included Article 31, which is the $5.99 outpatient clinics, which, and that's all it has in there. As many on the caller know, OMH is about to come out. They came out with draft regs. The 45-day public comment period was over last Monday, I believe, and it's going to include inpatient to inpatient and a number of other programs. My question is, will the DOH draft regs, will they get up to date with all of the inclusions in the new OMH revised regulation?
That's a good question. I think that's worth commenting on. If I'm not sure of the intent, and maybe it's because we're in just coming to the end of their comment period. But it would make sense that all regs align with one another and make it very clear, where services can be provided and from what sites to what sites. So I think that's something that is worth submitting a comment on and saying, your thoughts on that. But certainly, okay. I would hope the agencies would talk and try to align the two.
Yeah, in a similar vein, am I still on, David?
You are, Hal.
Yeah.
Yep.
In a similar vein, and I don't know the details, but understand that OASIS is drafting some telepsych or telemedicine regs as well, and to date they've been fairly silent on it. And but I again heard just this morning that they're in it too. So I think all the agencies mentioned in that draft, yes, it is worth a comment, and I appreciate you saying that. Mm-hmm. So it's OASIS and OMH, both should have the full extent of their regulatory scope included.
Mm-hmm.
Thanks.
Thanks, Hal.
Thank you.
There's a couple things I noticed just from looking at it this morning, and I'm kind of sharing the screen so you can see those regulations, the proposal there. Danny, I'll just nod your head if you can see them. Okay, good. Couple things, to take note of in the section on telemedicine, where there's a definition of distant site and originating site. We might typically call those hub sites instead of distant sites, or presenting sites instead of originating sites or spokes. But one thing I notice here is that doesn't really allow for providers to be, let's say, working out of a home office. They need to be in an Article 28 facility or in a physician's office, where the intent seems to be you need to be practicing where other patients can be seen. This is something that we've talked about before, and maybe in the future we'll talk more about this, the direct-to-patient care model. But here, one of the things that this regulation seems to do is it limits some of our specialists who might work for vendors like Insight Telepsychiatry or Forefront or something like that, or specialists on call, where they're actually providing services from their homes to a large degree. And that this seems to limit that. Another thing I just quickly noticed, under remote patient monitoring, there's a section here that is kind of interesting. It says remote patient monitoring must be medically necessary and should be discontinued when the patient's condition is determined to be stable or controlled. Rayanne, do you have any insight on what the thought around that was?
I don't have a lot of information. I think that is a recent addition, and my guess is that it is just an attempt to ensure that this isn't being used for every single patient who might just want it, but for the patients for whom it's really necessary. I don't know how that's really going to be assessed. So that's a question more for Joan to find out why it would be discontinued if a patient's, how it would be determined if it would be discontinued.
Yep. I know like some of our experience with remote patient monitoring has been, shorter time frames, so 30, 60, 90-day monitoring.
Mm-hmm.
But what's kind of interesting about this is, remote patient monitoring actually gives a patient the opportunity to be stable and have their vitals regularly sent, make sure that they're taking their medication, or at least, the question is asked. And
mm-hmm.
so the question in my mind around that is, well, it's actually a service to keep a patient out of the emergency room or out of the hospital if we keep them stable by doing remote patient monitoring. So it's kind of an interesting one. And then the other...
This is Mary Beth. Just,
hey,
I can sort of like understand why they would put something like that in a bill, because things have to be proven medically necessary for us to spend other people's money for them. And so they're looking for a medical necessity finding. And unfortunately, some of the literature is really not very strong that that remote patient monitoring, when patients are stable, actually does keep them out of the hospital. Definitely when they're not stable, there's some bend towards it being helpful. But otherwise, it looks like it's a convenience factor.
Mm.
And I know no one wants to hear that.
Yeah. The other, I guess, Hal made a note here too. Behavioral health conditions in particular. People need ongoing maintenance. So, I guess there's an argument to be made there, and some comments we could make. There's also a section here under remote patient monitoring about certified home health agencies, and I'm guessing this is because we don't want to duplicate payments or something. But it seems funny to me that a certified home health agency who really could triage their patients and be more effective with their existing patients using remote patient monitoring. It seems funny that would be disincentivized. But
David, again, that may be something we would want to clarify with Joan, but I believe that may have been added because we have our home telehealth program using remote patient monitoring that's spelled out in another section of public health law. So I know that there's been quite a bit of concern that about exactly what you said, either duplication of services or that this telehealth parity law sort of supersedes the home telehealth law that's been in place for a number of years. So my guess is that language is in there in some way to make clear that this is a separate, maybe a separate service from what the CHAs are delivering through the already established home telehealth program.
Okay. Any other questions or thoughts on that? We have a question again from Averill George about the location of the physician. So, Rayanne, maybe can you comment on that? What's the why does the location of the physician matter?
I actually can't speak to that. That is also another new development that was not, limiting the location of the physician was not previously in earlier versions of the draft regs. So we would have to rely on Joan to shed some light on that. My understanding previously had been that a home office would be an acceptable place for originating, an originating site of a visit, and that, as long as the confidentiality provisions later in the regs were adhered to, that it would be okay. So it looks like some decision has been made, more recently to make it be a practitioner's office. And my guess is that it has to do with concerns about confidentiality.
Yep. So I'll be emailing that to everybody that's on the call again. But you should again receive this through your PPSs if you're participating there. Here's another question from Dr. Hall. Can a physician who practices at a hospital outside of New York State be a provider under these regulations? Kent, I think here they make pretty clear later on in the regulations that you need to be licensed. Here it is, licensed pursuant to New York State ed law.
Correct.
Yep. So you got to be licensed, registered. I think too that if you're working in a hospital setting, you need to be credentialed with that hospital. I think that's the case.
Yep, that's true.
Okay. Other questions? Let's see. I'm going to try Iris here for a minute. Let's see, can I unmute you? Iris?
Hi, I'm here. Can you hear me?
We can.
Yeah, it's funny. Those are the 2 points that I've been kind of pounding along when I saw the first edition of this draft, and that is, my thought about the piece about the practitioner being at home. That's a huge deal breaker for provision of already short supplied specialty care. And can we not argue that if we are using a dedicated modem and a secure line in the home, that it's not an extension of the hospital that they are credentialed in and therefore secure? I don't know how much interpretation we can build into that, but it is a big concern for us. I understand the mobile piece completely, and I actually I support that to an extent because I think at this point in time we don't have good secure ways of in travel to use mobile devices and be really safe with it. But I do think that if you have this set up at home, we should be as a group making an argument for this. I would imagine it's a deal breaker for just about any specialty.
Yeah. Averill. Is that Averill George? George Averill? I think I unmuted your line. Go to the questions page. Oh, okay. Sorry. Judy from Northeast Telehealth Resource Center says out-of-state physicians need to be enrolled in New York Medicaid. And Averill says exactly. Is that the case too, Rayanne?
If they want to be reimbursed for, yes, yeah. for dealing with Medicaid patients.
Okay. So it's not necessarily that they need to be, let's say they're not going to be reimbursed by Medicaid. It's going to be Medicare or private insurance. Do they still need to be enrolled in New York Medicaid?
I don't think so. I can follow up with Joan to make sure.
Okay. So a lot to be kind of digging into in a short time frame to respond, but I'll get these out to everybody as soon as I can. Amanda Marie, did you have a question or a comment?
Hi, I actually threw it in this question box. Sorry, let me pull it back up. I just wanted, and I think you touched on it a bit, but I remember in the last call that we had last month, there was talk on PHL Article 29, and the originating site looked like a patient can be from home, given that they're undergoing telehealth visits and the remote patient monitoring. And I'm just wondering, and I guess it's a very similar question to the last that was asked, if a clinician is working from home and has all of the confidentiality rules in place, is it possible for the clinician to be at home and the patient to be at home? And what do we need to do to make that very clear in this language? Because I feel like every time I'm reading new legislature, that is completely unclear.
That's right.
Yep.
Yeah. I think we could. We should find out exactly there's nothing in the statute limiting the location of the provider. So apparently here in these regulations, at least for Medicaid providers, there's a limitation that's being spelled out here in these draft regulations. So, but yes, I think in the statute it's fairly clear about patients, the patient location, that the patient being at home is only reimbursable if they're receiving services via remote patient monitoring, but not for the video visits with a physician. So I think it's a little clearer about the patient. Maybe we need with the feedback on these regulations to seek greater clarity with the location of the provider.
And sorry, are you saying that the remote patient monitoring side will be reimbursed, but the actual televisits won't be reimbursed?
Telemedicine, in the statute, it does not guarantee reimbursement for visits where patients are at home receiving services via telemedicine. It does for remote patient monitoring because, by nature, remote patient monitoring, a patient's located in their home or residence.
I just feel like both of those are coupled together. And I don't understand why, and I'm sorry if this is naive, I don't understand why the actual visits through two-way audio, two-way video are not considered to be, a subclass of that remote patient monitoring, and why it can't be argued that they need to be together. Because, I'm assuming that that's all happening collectively, right? It's not like they're happening in very separate ways.
Yeah, I think
they could happen collectively. I think it goes back to the way the statute defines remote patient monitoring and how it defines telemedicine as sort of two separate things. So again, that's kind of spelled out in the statutory language. There's not a lot that can be done in regulation to sort of go against what those definitions are. But I think if you make the case that part of remote patient monitoring may be occurring through video visits, there may be able to be a case made and some greater clarity provided there.
Dr. Holman, I see that you've had your hand raised for some time, and
And actually, it's some of the very similar questions about this side of the patient, side of the doctor, because a number of the health plans for a while were covering, these visits as a way to avoid ER and urgent care. And it sounds like this would make those visits essentially illegal if this is a change in how medicine is practiced as opposed to just a payment strategy. The other question I have is New York State law, regulation or law, allows a physician out of state to do a consultation as a one-time piece. And I'm wondering if the way this is written would now not allow that consultation. Do you know what I'm saying? If you have a specialist in Boston and you want a one-time consultation, they could come into state, give you that consultation legally without having to be licensed in the state of New York. What would happen under telehealth, under these regulations? If you called that doctor, could he or she do that legally now with these regulations? I'm not sure.
It's an interesting question.
I don't think that this is intended to sort of supersede the state education law that says that consultations on a sort of one-time or infrequent basis can be done. So that's something else to look at. If this language is confusing and looks like it's sort of canceling that out, we should provide some feedback to that.
Yeah, it's definitely silent on it. So, and what does it do for the health plans who have a telemedicine setup for their patients, for their members? Is that now illegal? In quotes, air quotes.
Right. So more feedback there. Mary Zelazny.
Hi. Under confidentiality, you have, if you go down just a hair, David, you have right there, culturally competent translation services. That should be interpretation. Translation is written. Interpretation is verbal.
Good catch.
I'm assuming you mean verbal. You should probably have, I would recommend that they put interpretation and translation services, frankly, because a lot of, we're finding that a lot of the hospitals don't translate their own forms. So we have to do it for them.
That'd be nice.
Thanks, Mary.
Yeah, just because I see it now, this section on patient consent. This is always kind of an interesting one because, New York State, at least in the past, hasn't required a separate consent for telemedicine. So typically we want to say, if you have consent to treat, that should be sufficient. But it's a thought. Latoya, any feedback on that part about the patient consent? I know that's an issue across the country as well.
Sure, and there's no one way to do it. Our policy really is upholding the existing policies on consent. So if and most likely when a healthcare provider is obtaining consent for the service itself, the service that's already covered under that plan, then that particular consent should also be extended for telemedicine, but there should be no additional consent for telemedicine or telehealth provided services. We do believe, however, that the patient or beneficiary should be duly informed of all risk, but additional consent is something that APA considers to be an additional barrier to accessing the care that a beneficiary needs.
Yeah, thanks for that. Karen Roach, you have a question.
Yeah, hi, David. I actually had a comment, and it was going back to one of the previous questions relating to the restrictions and the definitions of originating and distant sites. I just wanted to point out, and I know some of the payers do mirror what the public, Medicaid or Medicare is doing, but the statute itself, it contains kind of a different set of rules for Medicaid versus for the health plans. So the part of the statute that related to the health plans is much broader. It does not even have all those definitions of originating site or distant sites. It's much more wide open, so that it would not, deem illegal any of the current programs that the health plans are supporting.
All right. Thank you for that. Cindy Gordon notes here, New York State only requires consent for psychiatry. And let's see. Iris Berman brings up the issue of providers, how it doesn't include paramedics. So I think, there's some question around New York State around community paramedicine and how telehealth could be a factor in community paramedicine. But kind of our take on that is that it's outside their scope right now, at least state. So until that opens up legislatively, we're kind of limited there. Other thoughts, questions, comments? This has been really good. I'm looking for hands. You're like back in kindergarten, aren't you? Like, please raise your hand. All right.
David, I have a couple of other updates from Joan as well, not specific to the regulations that I can share. And thank you, everybody, for that feedback. I did try to jot down some notes, but I would encourage you to submit all of that in the formal way of submitting your feedback. And again, if you have any data to support, there was one specific piece that I think Mary Beth noted that it isn't I think it was the piece about the ongoing remote patient monitoring. If folks do have data to support that needs to continue from your own programs or other data, you can certainly feel free to do that. I think the more information that's provided, the better. The other updates Joan wanted me to share were in relation to current reimbursement and what things look like right now. She just wanted to make sure everyone is aware that because Medicaid reimbursement for telemedicine has been in place for a few years, I think since 2008, that reimbursement has continued. It's still in place, and that's again for two-way electronic audiovisual communication. And the expanded list of providers should be covered now. The additional settings that have been added with the statute, that should all be in place. For store and forward and remote patient monitoring reimbursement, that is really dependent upon CMS's approval of the state plan amendments, which were submitted earlier this year. And although they don't anticipate any problems or concerns related to CMS's approval of those state plan amendments, the timeline is sort of unclear. So as we get more information about that, we will share that. She also mentioned that there is a telehealth meeting that is in its early planning stages and going to be hosted by KPMG for all of the PPSs. I'm not sure if this is something that you may have already heard about or gotten some information about, but tentatively scheduled to happen before the end of the summer, so that's coming up quickly, and when we have more information and in details to share with you, we'll pass that along.
Great. Thanks, Rand. Yeah, I believe that Caitlin and I will be presenting at that session.
Great.
So looking forward to it. I'm going to turn now, and we'll come back to Rayanne here in a little bit, but I just wanted to follow up really quickly on the OMH regulations. So we did send a response to their proposed regulations. The Fort Drum Regional Health Planning Organization did. So I'm going to just show you my screen here again. So I think you see on there our letter, and I'll send this with our email follow-up as well. But basically, it kind of gets to this section. Some of the comments that we put out there. Now, I got some feedback from Hal Smith from Westchester Medical Center, some feedback from Jennifer Earle at the Community Clinic of Jefferson County, and Tina O'Neill from Samaritan Medical Center. So they kind of helped me come up with some of the key points. But again, you'll be able to review all these points that we've made, and I'm hoping that you guys have responded as well. So if you have any questions about that after you've had a chance to review it, let me know. So we've identified quite a few things. Is there anybody on the line right now from OMH? I can't see a hand there. I don't recognize our friends from OMH. Okay. Well, just wanted to let you know that we are working on that. We'll see if there's any changes to what they come up with there. Okay. Let's turn it back now to Rayanne. And Rayanne, we've kind of had it on our agenda here for a little bit now, a couple months, to provide some input around these 3 or 4 key areas for SHIP, right?
That's right.
Okay.
Yes.
So go ahead, and I'll let you take it from there.
Okay. Can you remind me how to share my slides here, David?
Oh, yeah. Try this.
Okay.
Oh, just wanted to mention before you jump in, Rand, that got a note here from Iris Berman that Northwell submitted a response as well. So on the OMH regulations. Okay, take it away.
Okay, do you see my first slide here, or do you see all the background?
Yep.
Okay,
Yep.
great. So as David mentioned, a couple of months ago, I was on the call, I believe in April, to talk about the State Health Innovation Plan and the Access to Care work group, which is now looking at telehealth as a solution to some access to care issues. At risk of sort of repeating myself, I kind of want to go back through a couple of the key points about SHIP, just for the sake of the folks that were not on the call in April. And I'm having a hard time. Oh, there we go. Advancing my slides. So the State Health Innovation Plan has as its goal to get 80% of the state's population to receive primary care within an APC setting. And the background of this is that New York State received a $100 million grant from CMS through a state innovation model grant to help implement the SHIP. SHIP includes the components that I mentioned of promoting this advanced primary care model. It provides some funding to support regionally based primary care practice transformation activities, and is really focused also on promoting the use of value-based payments. So there, as you can see from the slide there, access is a key element of the State Health Innovation Plan and its implementation. You'll see several different pillars listed there, many of which have a specific work group or council dedicated to focusing on that aspect of the State Health Innovation Plan. So the Access to Care work group is looking mostly at the demand of healthcare. So it's seen from the patient's perspective, and we're looking to answer the question, can I, as a patient, access healthcare when and where I need it? And this is sort of the flip side of the coin of what the workforce work group is working on, which is the supply side, and looked at from the healthcare workforce perspective, answering the question, is there enough care provided of the right variety in the right places? So we're two sides of the same coin, and you'll see that some of our work kind of overlaps into that supply side as we go forward. We looked last summer and last fall at 4 broad dimensions of access, and these are our 4 A's: affordability, availability, accessibility, and acceptability. So some of the questions that we looked at are there spelled out. And then we also looked at those dimensions through 8 different lenses. So depending on your gender, your age, your geographic location, that might influence your healthcare access. So we worked for several months with consultants from McKinsey and looked at the data that was available to us here through the department and through various analyses that McKinsey conducted. And we settled on 3 primary issues to look at in 2015. And these issues are ones that are being advanced for one or more reasons. Either that we think they have a great potential for impact to the overall population or to specific populations in New York State, or that they're not being addressed fully within the APC model or by any other SHIP work group. So the first topic we're looking at is telehealth and its potential to resolve multiple access to care barriers. And we talked about those 4 A's of access. Adoption of telehealth, we thought, had the potential to impact at least 3 out of those 4, and really looked like it could be a solution for many access barriers. That leads me to this meeting and this group. The Access to Care work group has been internally staffed by Department of Health staff. It doesn't have an external body as many of the other SHIP work groups do. So instead, our approach has been to consult with already established groups of stakeholders to seek input on the issues that we're interested in addressing. And so with regard to telehealth, we met earlier this year with the Rural Health Council, and we'll meet later this summer with the Public Health and Health Planning Council. And because this group is one that has, I'm sure, very valuable feedback and actively engaged in telehealth implementation, we thought it worthwhile to also talk with this group. We know there's a lot of interest and momentum building in this field, but of course a lot of barriers that we still need to address as well. So the 3 specific areas we were interested in hearing about from you, and then we'll open it up to others as well. The first three are Project Echo, remote patient monitoring, and telemental health. And again, these are issues that we've identified not only because of their potential to increase access to healthcare services, but for a couple of other reasons as well. First, that we think they have potential for cost savings to the system, and that they're documented in the literature to improve patient outcomes. So although we'll talk about each of those topics, I would like to allow some time for you guys to raise other concerns that you have related to telehealth. We've talked about reimbursement a lot, but there may be others, either specific programs that you'd like to see advanced or other issues and barriers that need to be addressed. So I'll throw up some of these general questions for consideration. These were things that when we spoke with the Rural Health Council, we put up just to have them think about. And I think we're most interested in finding out from you the implementation barriers that exist. And, you know, if we do this, how do we engage providers? How do we engage patients? How do we pay for it? Are there other implementation barriers? And any policy or regulatory considerations as well. So we'll start with Project Echo. And are folks on the phone familiar with Project Echo?
Yeah, Rayanne, as it turns out, we have kind of an expert on Project Echo in our audience.
Awesome.
So Michael Hesselberg is on the line.
Oh, great. Fantastic.
Yep.
So I don't want to go into it in too much detail, but Project Echo, you know, we're looking at it here in this work group, even though it's not really telehealth because it doesn't involve the clinical interaction with the patient, but because we see that it has a lot of potential to expand upon the capacity of our already existing workforce. So where our workforce work group is focused on trying to see how we can recruit more people to practice in more rural areas of the state, and how we can better train them to be able to handle all of the everything that they'll need to know to be able to be part of an advanced primary care model. Project Echo seems to be, you know, a different type of solution to that. So that's why we wanted to raise it as a potential model to look at and explore. And so I think I'll just leave it with that. And David, I don't know how you open it up to everybody, if you have to unmute folks or if you want them to raise hands, but I would love to hear from folks about either your experience with Project Echo, any barriers that you see, and we'll jot down and provide feedback. And I should back up by saying that the reason we're collecting this, gathering information, is that, you know, each body that provides feedback, your information would sort of be written up into a report or a set of recommendations that we can then advance to the Innovation Council, which oversees the entire implementation of the SIM grant, and with the hopes that if there are any recommendations for policy change or regulatory change or any funding that is needed, those are the types of things that we're looking to be able to advance and to be able to have some have it come straight from the folks who are out there implementing these types of programs.
Okay, with that, as Rayanne said, if you have a comment or a question, and I expect I should hear from the University of Rochester folks, go ahead and raise your hand and I'll unmute your line. Let's see, well, Michael, I thought you might jump in there. Go ahead, Michael.
Hey, thank you. We've had a lot of success with Project Echo, actually. We launched Echo, the first Echo in New York State, about 2.5 years ago in geriatric mental health for primary care. And over 2 years, we had over 500 attendees across 32 counties in New York State. Our data that's come back, the qualitative data, looked great. Participants really liked it. They felt that it improved patient outcomes for the older adults that they serve with mental illness. And then we looked at claims data from Excelis, and we had over 20,000 Excelis beneficiaries, and we were able to show a reduction in ED utilization and ED costs of older adults with mental illness who are Excelis beneficiaries. We then kind of expanded from there, where we started a general psychiatry echo for primary care, and that's up and going. Our geriatric mental health echo is kind of merged into the long-term care setting, and that's up and going. We have over 63 nursing homes participating in that. Our echo in general psychiatry and our echo in geriatric mental health for long-term care are embedded into 2 district projects, and the Finger Lakes PPS, and then the Leatherstocking PPS is interested in our general psychiatry echo. And then we've received grant funding for several more echo initiatives, and we think by 2017 we should have 10 different echo programs coming out of the University of Rochester.
Right.
Michael, and do you know what those topic areas are going to be? I'm just curious if you know what types of chronic disease.
Yep. Hold on one second. So palliative care will be one. We're going to have a hospital medicine echo. We're going to have an HIV echo, an STD echo, a hepatitis C echo, an autism echo, pediatric epilepsy echo, and an eating disorders echo. And then that's on top of our general psychiatry echo and our geriatric mental health for long-term care echo.
Michael, this is Mary Beth. I heard through Ann Greep that there's also one on substance abuse.
Yes.
So, this month or last month.
OASIS funded Excellus and Huther Doyle to start up chronic pain and pain opioid dependence echo, and they launched a couple of months ago. So right now we're the only 2 echo hubs in New York State, but our understanding is that there are a few places down in New York City who are interested in getting it up and going. I think Northwell being maybe one of them.
Michael, I'm wondering, what are you seeing as some of the barriers or challenges in implementing echo?
The biggest challenge is we're in a volume-based reimbursement mechanism, and no one wants to pay for somebody else's education. But as you move to kind of a value-based reimbursement mechanism, echo fits in very nicely. So we're already looking at sustainable models, looking at managed care products, building it into our accountable care shared savings. So I mean, we're exploring that, but sustainability for this model has been very, very difficult because there is no provider to patient interactions. It's provider to provider.
David, can you hear me?
And Danielle, go ahead.
Great. So this is Danielle Latter with NEPRC, and I would just echo play on words there. Thank you so much, Michael. It's so exciting to hear how much you're expanding. We had Michael come and speak at our NETRIC conference a couple years back, and everyone got really excited about it. And many of the NETRIC states are extremely interested in ECHO and how can they participate and or build their own hub and spoke network of ECHO. And just like Michael had mentioned, getting creative and how to sustain it, whether it's through ACO models, et cetera, because that's always been the issue. CMS has talked about how valuable it is when you have great outcomes like Rochester has had, and you can actually show wonderful outcomes and cost savings and through your pilots, but it's taken a long time. Robert Wood Johnson has funded a lot of ECHO initially and has seen a lot of expansion. But again, I think it's a perfect match for the transition to the value-based models that we're all looking at across the U.S. and across the region. So I'm hoping, fingers crossed, that there will continue to be great data coming out and that we'll see key players starting to fund and or support funding for it long term, because it not only, you just think of the vast replication that's possible. The traditional models of telehealth, telemedicine with a provider, a specialist provider, increasing their ability to provide services directly to patients is great. But when you talk about really increasing the capacity through something like ECHO of existing rural providers to see and keep patients local and therefore keep more money local and decrease costs associated with those patients having to go to the ED and or in hospital, it's just sky's the limit. There's a lot of opportunity there. So,
Michael, any other pushback, I guess you might call it, or resistance from primary care doctors around ECHO?
I mean, timing's always an issue, and again, that goes back to the reimbursement mechanism. In a fee-for-service arena, you get paid in primary care by how many patients you can crank out in an hour. So to ask primary care docs to leave a busy practice for 90 minutes every other week to come to essentially an education program is a tough sell. But the way that I marketed the program was I started with executive leadership of health systems, and my sell was, if you guys don't start taking good care of these high-cost patients, it's going to drain you kind of downstream. And so once you got buy-in from that leadership, they would actually protect their primary care providers in certain practices to participate in the model. And to be honest, when we started this 2.5, 3 years ago, I was very pessimistic that it wasn't going to be successful in New York State. And, again, the first reason was because of the reimbursement mechanism in our state. And the second was we started in geriatric mental health. And the reason why we started there is because I'm a geriatric psychiatry provider and knew there was a need. But, I was going, how am I going to convince these docs to become experts not only in geriatrics, but geriatric psychiatry, where these patients are very time-consuming, they're very complex, and the reimbursement's horrible. But I was very surprised. And like I said, we had engagements from practices across 32 counties, and it's still going strong. And in our long-term care setting, where it's a low-hanging fruit, they're loving it, the nursing homes. And kind of piggybacking off of Harvard's work with this model in long-term care, they were able to show a substantial reduction in antipsychotic use in those facilities that participated in ECHO. And we all know in long-term care, that's an MDS quality indicator for those facilities. So, we're just, really our didactics, and we try to keep our cases focused around quality metrics, knowing that that's where cost sharing is going to be tied to in the future. And, our hope is that value will happen, and so this will fit in very nicely in that type of reimbursement mechanism.
Good. Mary Lasney, did you have a comment or a question?
Yeah, I do. Years ago, we were funded through, Chicanes actually was funded, the Primary Care Association for FQHCs, and we did our own Project ECHO. We didn't go through the official Project ECHO, but we created our own, and we used our telehealth network to run the backbone. We got taught everybody how to do, video, how to connect. And then what we did is we engaged the specialists that ran the program. It was on Hep C, and the goal was to try to work with primary care providers and get them more knowledgeable and comfortable on Hep C patients, because we're trying to drive those patients to the primary care sites. And it was highly successful, and we did not have to pay, because Project ECHO is pretty expensive. It's a great model, but you can do it without actually going through Project ECHO if you want. It's not that difficult to do if you have the technology behind you, which most, some of us do, and I know, David, you do, and there's others. So I think it's something to consider, because it is pretty costly.
Mm-hmm. Michael, just a quick question for you from Dr. Holman. You guys do provide CMEs for Project ECHO training, right?
Yes, we do. We provide 1.5 CMEs for every clinic folks come to. We're also working on getting social work education credits, nursing home administrator credits set up. But speaking to Mary's comment with the cost, it is a costly model to get up and going. But once you get it up and going, the costs do go down for the model. Really, where the costs of the model are significant is paying for the specialists to sit around that table, a small percentage of each of the specialists. But again, the potential downstream financial benefits of a model like this through this force multiplication and building capacity of providers to serve even larger groups of patients, I mean, that potential savings should easily offset that cost, we think, versus a traditional, I mean, I also run the telepsychiatry program at the university, and in my telepsychiatry program, we only can reach one patient on the other end. I've got a provider and one patient. Through ECHO, I'm training a provider at that end that can manage a whole caseload of patients. So that's where we think that there's a significant difference.
Good, Reanne, has this been helpful?
Yes, it is. I just have one more question. Michael, you said there was some, I'm familiar with the qualitative data from your program, from the geriatric mental health. When you spoke about the claims data from Excelis and the reduction in ED utilization and cost, is that, you know, is there a report from that or something you could share with me from that?
We just submitted a manuscript, so it's
okay.
We're waiting to hear back. So once I hear back, I can definitely share that with you.
Great.
All right.
No, this is helpful. I'm in the interest of time. It's 3:12, David, and I see that there's something on the agenda right after this discussion. Do I need to save some time for that?
No, just go right ahead. The other thing to take note of is really just a future item for discussion around direct-to-care. Just looking at that model, and that could be a topic for our discussion in the future. So go right to the end, Reanne.
Okay.
Take the time.
Okay. The next telehealth modality we wanted to look at a little more closely is remote patient monitoring. And again, with this group, I don't need to really provide a definition or explain what that means. When we took this to the Rural Health Council, one of the things that came up with remote patient monitoring is that in some areas of the state, there's still a lack of broadband access, and which limits the ability to use that, or you have to kind of work around that in some areas of the state. So I'll just throw that out there as one thing that's already been noted. Are there other issues or barriers related to remote patient monitoring that we could take a look at?
If you want to jump in on that.
Caitlin.
Go ahead, Caitlin.
So the couple of organizations that I'm talking to, I work with our project manager on our hospital to home, and telehealth is one of the initiatives there. The biggest barrier from organizations I find is the lack of broadband, but also the cost. And a lot of the organizations, they don't need too many units to get up and started with traditional remote patient monitoring. And a lot of the companies tend to put like minimum amount of units that you have to get. So there's the cost barrier, and then there's also the lack of being able to actually get the number needed for companies to really look at wanting to use them. And just, so those are the two things besides broadband, but broadband always comes up as the number one.
Can you say a little bit more about the cost? You're saying that there's a required minimum number of devices that you may have to?
Yeah, a couple of the companies we've looked in, they require a minimum amount of units that have to be leased or rented, however you want to term that, or bought. Otherwise, they tend to see it as a pilot study, and they don't see it financially feasible for them. But I've got smaller organizations that don't need a lot to start off with. So they kind of get locked in with that, and then there's just the general issue of cost. The reimbursement side for remote patient monitoring doesn't always cover the cost that they need for the equipment, because a lot of them will tack in cellular data. If you don't have access to Wi-Fi, but you have access to cell service, you can buy additional data plans for the units when you put them in homes. So the costs kind of keep adding up for them when they go to actually implement programs.
Okay, thank you.
Welcome.
See other thoughts or comments there? Not seeing any, Reanne.
None? Okay, well, what about this? Thinking about different models, I mean, this has been done through home health agencies quite successfully, and one thing that the SHIP is focused on is this idea of an advanced primary care model. So are you seeing any models or aware of any that are really operating right through that primary care practice, or is that something that's not really workable? How does the primary care provider, how is that worked into this type of, using this type of modality?
I can comment on that a little bit. So we had a remote patient monitoring project. When we looked at the cost for a primary care, maybe a small primary care office, the cost of purchasing equipment and what they could actually bill was, vastly different. So the billing just wasn't sufficient to cover the cost of equipment.
Okay.
And I think it's difficult to, even as Mary Beth said, it's difficult, even though there's tons of research and literature to suggest how powerful remote patient monitoring can be. I have pages and pages of documentation on that. It's a hard case to make. So you have to find true believers to adopt.
Yes. The only other way I've seen primary care incorporated into it is just that they're going off of the parameters for vital signs that the primary care doctor sets when a patient has been discharged and they're going into like a CHA for the follow-up visit for, that 30 days or the 60 days. Most of the involvement is just, well, if they're outside of this parameter, this is when we should check them out, and then they just kind of get updated with reports that are through the system.
Okay.
The other thing that I find with the few organizations I've talked to is they say the only way that they've had true success with doing remote patient monitoring when they actually get project access is having a designated person to actually review all of the data. If it's being split between all the different nurses that are involved, they don't get quite the same effect as they do if they have a designated person that kind of triages all of the information coming in.
Okay.
Yep.
Okay. Any other thoughts on remote patient monitoring?
Any other questions or comments out there for Rhiannon?
Okay. Our last piece is telemental health, so we'll maybe have a few minutes left to talk about that. And we're specifically talking about using live interactive video conferencing for provision of mental health services. So it sounds like from earlier in our discussion about the draft regulations that this idea that reimbursement can only happen if the provider is located in an office setting maybe will impact the use of telemental health, since some of companies like Insight Psychiatry, telepsychiatry, or just providers who are operating out of a home office would not be able to be reimbursed. So that's the first thing I have on my list that I heard from earlier in the call. Are there other barriers or other thoughts about using live video conferencing, concerns or issues?
Yeah, this is probably our biggest area of focus. So most of our patient encounters have been around telepsychiatry, a little bit with psychology, and of course the biggest issue is always providers. So just finding a psychiatrist who's willing to do this is pretty challenging. And when you find someone, sometimes the barrier is how they're going to do billing. So I'd say most of the vendors, like you mentioned, Insight Telepsychiatry, and some of the university settings, the models that they want to do telepsychiatry around are where the spoke site will bill. And that's a challenge in the sense that the presenting site, the spoke site, is doing a ton of work to begin with, just to present a patient, and then to ask them to take on billing as well as an extra step, and a lot of work. So finding a provider, number one, but number two, finding a provider who's willing to do their own billing. Those are challenges that we see. I don't know how
Especially
DOH
with child and adolescent, sorry.
Go ahead.
Especially with child and adolescent psychiatry, there's, I think, even more of a shortage than just adult psychiatry in this area. We've got a couple organizations that don't have one, and they can't get one, but they can't provide it through telepsychiatry because they've got to go through a vendor company, and they can't find a vendor who can legally do it in New York State because of the because of the regulations.
Is there anything, speaking to that Project Teach has been able to offer through the Office of Mental Health program? I know a little bit about it, and I know it just was refunded. Are there folks who are able to use that as a resource?
We do have a few organizations that use Project Teach in our area, but I think the amount that would actually need to utilize it completely would overwhelm our Project Teach, because it's just through Four Winds in Saratoga, and we've got like 11 plus counties that would be associated with that. So it's not quite at the level that they would need it.
Okay.
See, other thoughts or comments on that?
I can just throw something in quick. It goes back to when we were discussing remote patient monitoring and having telemedicine kind of under that. I do have a couple home care agencies that, when they can get broadband, would find it really helpful doing the remote patient monitoring equipment to be able to do video chats with some of their patients, especially ones that have COPD that get really anxious when they can't breathe, to be able to see a nurse and have them talk through breathing exercises for them to calm down the anxiety, they said, would be absolutely amazing.
Okay, so to have that ability to have that be the reimbursable service as well, or?
Yeah.
Okay.
Here's a question from Iris, or a comment.
I just need to understand why people are working with vendors. I heard somebody mention Insight as opposed to just if you've already got a telehealth tool. I think I need to understand that. And we're able to provide within our area both pediatric and adult telepsychiatry, but we've built our own program. I'm not sure.
Iris, we'd certainly love to work with you guys.
Yes.
Yeah, if you have capacity, that's always the challenge.
Right.
You know, the capacity of a psychiatrist. So those things have been tough for us to find. That's why I think people go to a vendor, because they can't find a regional resource.
So you're talking about a vendor in terms of the resource itself, and not so much the program, but the provider. Okay.
Yep, just the providers.
Yeah, I know most of our organizations would prefer to keep it regional, but we, like David said, we just don't have the capacity for the few that we have in this area to take on any more. And we've got a couple organizations that say that their providers want to retire, but they can't because there's nobody to replace them.
All right. Other questions, comments?
Okay, well, thank you everyone for the insight and feedback you've given. I just put my contact information up on the last slide. If you have any other thoughts that you'd like to share, my email address is there on the screen. Joan Cleary-Myron is the head of the Access to Care work group. I think she was on the call earlier, but I don't know if she's muted or able to talk, but her contact information is there as well. And then we also have a general telehealth mailbox now at the department. So if you have any other questions related to telehealth as we go along, you can use that telehealth inbox, and we try to triage those questions out to the appropriate parties to respond to. There's also a lot of information on the DOH website about the SIM and the SHIP and APC and all of that alphabet soup. So I've provided that on the slide as well. So thanks again. I'm going to probably take a listen to the recording of this session and try to write up some of the specific feedback you've given and advance that up to the work group for consideration.
Thanks, Ryan.
Thank you.
Joan, did you want to mention anything there? I think you're still on.
I just think Rand does an excellent job summarizing what we're up to, and I just appreciate all your feedback. You always give us a little different perspective than other groups we consult, so thank you.
Great. Well, thanks everyone. I think this has been a really good session today, and looking forward to being with you again next month. So thanks again. We'll sign off and say goodbye.